Good morning, everyone, and I almost said good afternoon because it's noontime here in New York. But my name is Kevin Garrett. I'm the Senior Manager of the Center for Quality Improvement and Innovation. And today I'm going to talk to you about conducting a quality improvement project. Before I do that, I just want to preface things a little bit, even before I get into learning objectives, which you can read through. But, you know, I was sitting here waiting for this to start, and I'm looking out my window. I'm on the 13th floor, and it's pouring rain in New York. I'm watching all little people scurry down there and their umbrellas and what have you, and I'm looking at all this data that's in front of me. You know, I see a bunch of people, don't quite know where they're going, but I can count them. If I had a little collector, I could count the raindrops. But that in and of itself wouldn't really tell me anything. And I think a lot of times we are asked to collect a lot of data, to count the raindrops, if you will. But we don't do anything with it. We don't have the guidance to do that. We don't understand how to put that into improvement, how to put that into practice, and how to continuously use things like that to improve. So that's one of the things that I really want to stress today. This is about improving. This is not about collecting data for the sake of collecting data. For those of you that are funded through whatever federal agency, you have a lot of data requirements. A lot of times that data at whatever level gets thrown in a drawer and they say thank you and come back next year with your piles of data again. And that's it. And that's not acceptable anymore, okay? What is acceptable is when we all kind of focus our efforts on making our services better to our clients. And that's really the kind of underlying theme of this today, that the real charge moving forward is to take what you have, learn to use it, learn to improve, and learn to keep improving, because it's never ending, okay? Things that might have been acceptable even 6 months ago might have some flaws that you may want to take a look at and say, oh, well, we can even do better than this. And I'm sure that most, if not all of you, are doing this now, okay? You're doing it to whatever degree. But my challenge is that there's another degree, and there's a degree on top of that. And that's really what we're going to talk about, and hopefully give you the tools and give you some ideas on how to get to that third, fourth, fifth, et cetera level. So I'll just go over the learning objectives again. Basically, to understand what your data is telling you, making sure you're choosing the right measures that fit your needs, basically. And then finally, developing improvement projects and maintaining the gains that you made. So let's talk a little bit more about data. I mean, you have all these potential sources, and you can read through this with me. Actually, is there anyone listening on the phone? I should have asked this up front. Is there anyone listening on the phone that is not seeing the slides? I don't know how other than to take you off mute to do that. Estella, is there a way that somebody on the phone can come off mute just to let us know that they're there but not in the chat room or the webinar? I'm not quite sure. But we'll ponder that, and I'll move forward in the meantime. Go ahead.
Well, I was going to say they could raise their hand, and I can unmute them, or they could send a message in the chat.
Okay. Yeah, I was thinking of just people that are on the phone. That
I see. Yes.
Yeah.
Well, you could send me an email at estella@uic.edu and let me know that you can't see something, and that should be fine.
Okay. Good. Okay, that's great. Thank you. So basically, as you can see here, you have a lot of different data sources. I could have filled up 30 slides with different data sources and things like that. But that's not the point, though, because what we just mentioned in the beginning is that you want to then take that data and do something with it. And the first thing you want to figure out is if not only what it's telling you, if you're collecting the right data, okay? If you're collecting the color of sneakers that some of your clients wears, that's probably not the right data. It's got to be meaningful. It's got to eliminating waste. It's got to go towards improving something, okay? Also, one of the beauties of collecting data and choosing the right measure is that there are always perceptions. Perceptions may be valid sometimes, but data will really tell you what the reality is, okay? And then you also need to understand what tools you can apply to your data and to choose an improvement project that will help you in moving forward and having that continuous cycle of improvement. So I want to backtrack a little bit, and I think we did this in June or something, but the HIV/AIDS Bureau Policy Clarification Notice 1502 requires that you have at least one measure for each funded service category. And then highly utilized service categories need two measures. Now, this applies to the Chicago EMA, right? However, that kind of rolls down to you guys too, because then you will be responsible for collecting data for these measures that are mandated. And for whatever you're funded, you will need to collect data and have at least one improvement project going on at a time. The policy clarification notice also sets out that you need to use tools to help you identify the problems. I threw in some tools there. There's a lot more, a lot more. If any of you are familiar with ASQ, they have a really interesting website, and there's a real good definition of what's commonly called the 7 tools of quality. These are some of them. I won't talk about all of them, but the 7 tools of quality really kind of span a gamut of starting at checklists, something very simple, to something a little more complex like a histogram and a Pareto chart that really kind of look at causality and things like that. So I'd encourage you to go onto asq.org. It's got a wealth of information, even if you're not a member, and it's publicly available. So again, we talk about tools and understanding your data, how they help you identify potential problems. And that gets you kind of halfway to understanding what to do next. Because your data, even with all the tools and things like that, are going to set out for you things that may or may not be occurring, things that may or may not be good or bad or whatever. The problem with that is that you then are faced with a lot of choices. And, excuse me, you really need to kind of sift through that, and I'll talk about that in a minute. But you can see here, when choosing a measure, some of the things you need to consider. And also, one of the things in the policy clarification notice is that they talk about having the measure be kind of germane to the service category, which makes sense, right? I mean, when you think about it, if you're funding a food bank, viral load suppression, although important for everyone that we treat, it's going to be really hard for that food bank to collect. But there are other things that they can collect that will help them understand where their patients are and help them understand how their services are going and help them understand how to improve. So other things to consider when you choose these measures is the patient impact, okay? Are you going to overburden your patients? And will what you're collecting lead to an overall benefit to your patients? What is the impact going to be? Is it a health outcome? Is it an increase in screenings or tests? Is it better adherence? Those are the kind of things that you need to consider, because those are the kind of things that really kind of fill out your work plan almost. If you think about it, collecting data is a task, and in some cases it's a daunting task. Some folks may not have electronic medical records. Some folks may have to do this by hand all the time. You may not have the staff to do all the things that you're being asked to do. Those kind of things kind of enter into the thinking that goes into choosing a measure and collecting your data and then seeing how to improve. So a little bit more about understanding your data. Term that's become popular is drilling down your data, but basically what this means is just doing a deeper dive into it, looking at more of the details in it. If you used to report on the fact that we have 236 clients, well, okay, that's great. How many male and female clients do you have? How many persons of color do you have? Are your services really pertinent to the clients that you serve? If you don't drill down your data and you don't understand what's going on with that, then you may not be meeting their needs. So a little bit further on that, you really want to talk about what are the barriers to the care that you're giving, okay? That to me is one of the most important things, because you can't be all things to all people, although I think it's really good that you might want to try to be better to most people. I think that without drilling down, obviously, you're not going to understand the richness of the client base that you have, okay? Drilling down your data also helps you look beyond the numbers. As I mentioned, if let's say you have a lot of clients that are over 50 and that are African American, well, there are certain things that are applicable to that cohort that maybe are not applicable to females between the age of 18 and 35. Don't know. But there are things within the data that will kind of guide your work, all right, and guide your areas for improvement. The other thing that I would say when you start to drill down into your data, everybody should be involved in the process that's involved in patient care to some degree or another. It doesn't mean you have to get 60 people into a room and start battling over viral load suppression. It's more about getting everybody to understand what you're looking at, communicating with them about what you're trying to do, soliciting ideas from them about what they think you should be trying to do. In a lot of organizations, there's a quality team, right? And no matter what you call it, they're responsible for setting quality priorities. They're responsible for looking at the data. They're responsible for looking at the quality management plan and making sure you're on task with that. So the input from, let's say, the dietitian, somebody you may not think about, their input might be very important for whatever reason. And if you don't solicit everybody that's involved in patient care to one degree or another, you're missing those things. And that does your patients a disservice. And it also does you a disservice. So these are kind of an outline, 4 steps, basically. There's other things you can do too, but this is kind of a general, this is what you should be doing. Excuse me. And this one focuses a little bit on viral suppression, because I think nowadays we all want to focus on viral suppression. But within your measure, okay, you're going to have some that don't meet the defined criteria. Identify the reasons why each patient is not. And whatever you call your team, whether it's a multidisciplinary team meeting, the quality team, whatever, the quality committee, figure out why. All right. There are tools available to help you do that. You can use a histogram in something like this, where you can kind of, I call it batching ideas. One of the graphs I did once was reasons why people don't follow up with their TB test, right? So it's not just numbers. It's numbers within categories and reasons. And then you want to tally the reasons. And then you want to develop targeted follow-up plans. And the reason why you want to develop the targeted follow-up plans is to really address the specific issues of the groups of individuals that you've identified. All right? And that gets you closer to improvement, because once you start to understand who those folks are by drilling down into your data, after you've collected all this data, then you can develop plans on how to address their needs because you understand them a little bit better. So basically, in the last slide, excuse me, I'm losing my voice already, we suggested developing a reason why each patient is suppressed. Okay. Back to the histograms again, that's one thing that you can use to think about what's going on. Another thing you can use is an affinity diagram. There are many, many things that you can use, and bottom line is that use something that you feel comfortable with, okay? Folks get thrown by histograms simply because it's not like a run chart where you have, 37, 42, 63, 19, all in a little wavy line. A histogram, as I explained, kind of uses categories, and then you count the number of people that fall into that category, and some people will show a histogram as almost a bell curve, if you're familiar with that. Sometimes they look very nice like that. Sometimes they don't kind of work out that way. But no matter what tool you use, it'll help you make sense of your data points. And then from there, you focus your improvement efforts, right? Now, there's other things that can help you focus your improvement efforts too. And I'm going to talk to one that's in here. Excuse me, hold on one second. Sorry. I apologize for keep clearing my throat. So before I get to the other tool that I was going to talk about, this is an example of an affinity diagram where you have, let's say, there's 34 people in our presentation right now. If we were in a meeting room and I gave you a pad of Post-it notes and we decided that we want to focus on something, okay? And then I just say, okay, write it down, post it up on the board. If you look to the left, that's what it's going to look like. So what you need to do is basically turn it into something that looks like what we have on the right. And you group things by kind of categories. So in a way, it's its own little histogram, right? And then if you notice those dots there, the dots are actually people voting for the categories where they want to focus. That's very important because, again, it's a collaborative process. So it's important that all the stakeholders that put up all these notes and then the staff person that turned it into what you see on the right, all the contributors have a say in where the focus is, in where you're going to spend your time, and what you think is the most beneficial to the organization and to your patients. And then this is the histogram that I was talking about. So for patients that are non-compliant with a TB test, right, and when we used to do the PPD tests, there were a bunch of reasons why folks just didn't come back. I took from a medical record, actually at a pretty big hospital system, and put this chart together just to kind of look and see what was going on. They had a very good rate of return considering the number of tests that they did. But if you look at it, the test's not done at all because it wasn't documented. There were 57 people that had undocumented tests. There were 32 people that had their tests done, but the client didn't return to have the results read. There were 25 people that had their test done, but the result wasn't placed in the proper section in the record. And then you can see from the rest of the graph how that shakes out. So that's a typical histogram. Now, if I wanted to put that in sort of a bell curve thing, I could. And obviously, the test not done, 57, would be in the center of that, and it would go to the left or the right, and it would sort of look like a bell curve. What that tells you, sometimes it doesn't tell you anything, okay? What really is most meaningful is how you've drilled down yet again. But is that enough? No, it's not enough, okay? There could be hidden problems. There could be things going on in your data that you don't necessarily see right away. And I'll talk about variation in a second. But basically, looking at it doesn't really tell you everything that you need to know to start to figure out improvement, but it's a start. It's a really good start. But there's other things that can affect your data. So variation is kind of, for lack of a better term, it's kind of the noise within a system, right? If you look at a run chart, and you know, it's an 18-month run chart, and it's your clinic's viral load suppression. And let's say the results are somewhere between 80 and 87. At any given point on that run chart, nothing is higher than 80, nothing is lower than 80, nothing is higher than 87. So that's pretty smooth. However, there's noise going on in there because it's not all 87, right? So there's some normal fluctuations. A special cause would be if all of a sudden something dropped down to 40 for a month. Now, that special cause could be because only 2 patients were seen and the clinic had to close because a water pipe burst down the street and you could only see the 2 sickest patients that you had. Those are the kind of things that are unexpected. They create havoc in a system for the most part, although sometimes special cause variations can be positive. There's a whole presentation we could do on this and how to use a control chart to really quantify common cause and special cause variation and really take a look at your data. And if anybody's interested in that, I have a presentation on it that I'll be more than happy to send you. And you can get a hold of me through Estella. I want to stop at this point because I kind of feel like I'm rushing through this, but does anybody have any questions? I'm looking at the attendee list now, and if you raise your hand at the bottom of the panelist list, there's a little hand in the lower right-hand corner. And if you do have a question, either type it in the chat room and let us know, or just raise your hand and we will do our best to get to you. I'm hoping everybody can see the chat room. I think so. Okay. Okay. I'll go on then. So again, it's a start, okay? This client level data that you've drilled down is going to inform your improvement ideas. Yes, more global data will give you the opportunity to look at things like variation. It exists. It's pretty interesting how it gets buried sometimes in your data results, especially in things like viral load suppression or any kind of run chart over time. And you really have to do it over time, by the way. But it's a linear look at what's going on in the system. And the really interesting thing is that there are hidden little gotchas in there in a lot of times that basically will just give you some idea that there's something that you really need to do a deeper dive in again and take it from there. So I'm going to head to the next slide. I thought there was something being typed in the box. Okay. So let's just look at this summary. And I'm not going to read this to you. Take a look at this while I kind of talk through it. Again, this is the first part of really what's going on and looking at your data, deciding how to act. But it's that third one at the bottom that we're really here to talk about.
Excuse me, Kevin. We have a question. Yeah. Hold on.
Yeah.
Let me unmute her.
Okay. Michelle. Okay, good. Okay. Hi, Michelle.
Michelle, you're unmuted. Michelle, do you have a question? Okay, maybe she can ask it later.
Okay. While we're on the subject, though, does anybody else have a question? Okay. So in the first part of this, we talked about data, the importance of drilling down. Now we want to talk about developing a quality improvement project. Okay. As I kind of alluded to before, your data may tell you multiple things that are going on. And that could be good, that could be not so good, simply because with multiple things going on, how do you know what to do? Okay. Just to give you an aside, I was reading a book on lean, and it was written by someone who is is an expert in lean and implementing it in healthcare settings, specifically large hospital settings. If any of you have ever had the misfortune to go to the ER before, you know that you spend a lot of time in the ER. So he looked at some studies that examined the time spent in an ER, and on average, people spent 10.5 hours in the ER. Now, he also looked at the amount of time that the patient interacted with a provider, the amount of time that the patient just sat there idly, and the amount of time that things were going on behind the scenes for the patient's benefit. And I'll let you guys guess, and you can type it in the chat room, just the number of hours that things were going on for the patient's benefit, whether it's sitting with the provider or things going on behind the scenes for the patient's benefit. How long do you think that is out of that 10.5 hours? Let's take a guess. Anyone? Oh, okay. Here we go. Estella, I'm not seeing anything typed in the chat.
Yeah, there's nothing typed in the chat right now.
Oh, okay, good. So there's 3 people that I'm going to start with Donna. Donna asked a question. And Donna, I don't think you're muted, so you want to try asking your question? Or type it in the chat room. Okay.
You want to go to Katrina?
Yeah, yes. So Katrina, I just unmuted you.
Oh, I guess like a half hour? I don't know.
Katrina, do you have a question? Katrina Boone?
Oh, no. I was just guessing.
A half hour. Okay. Thank you.
Yeah, maybe.
Thank you very much, Katrina. Okay. So Michelle, I just am not able to unmute you. So sorry about that. And then Samantha, I just can't unmute you either. And you have your hand up. Oh, good. Thank you. So Samantha, you want to take a guess?
Samantha Mitchell, you had your hand up?
Oh, I just guessed 4 hours. I typed it in the chat box. Sorry about that.
Oh, that's okay. Thank you, Samantha. So basically, it was a little bit under an hour and a half. That's the amount of time that things were going on either for the benefit of the patient or with any specific interface between a provider and the patient. Under an hour and a half. So that means that there was 8 hours and some change that was just basically waste. And from a lean perspective, that is a big lean no-no. If any of you have worked with lean or been exposed to lean, you know that waste is what lean seeks to end or to control or to eliminate. It's very, very serious, and it's all about delivering value to the customer. And waiting 10 and a half hours to get 90 minutes worth of service is not delivering value to the customer. So clearly there's some problems in an ER. And this is universal. I mean, I've been in the ER a couple of times myself. And I think my shortest stay was over 14 hours. So it's a frustrating experience, and it certainly doesn't deliver a lot of value to the customer. Anyway, so when your data starts telling you a story, hopefully it'll just give you a nice, clear path to be able to set up your priorities and move forward with improving. But what if multiple priorities come up? What do? Right? So if I were going to take that example of the ER, and I'm going to start looking into it, I can pretty much guarantee that there's not just one thing that is happening that is keeping the patient there for 10 and a half hours. There's probably multiple things. So I then need to figure out what are the multiple things, and then I need to prioritize what I want to fix first. Now, if you think back to the histogram a minute ago, and maybe it'll be helpful to put that up again. Bear with me 1 second. If you look at this, chances are you would say, okay, well, where I can get the most bang for my buck is the 57 people. Because for some reason, the test wasn't done on those 57 people, so I can find out why. Well, okay. However, where you really might want to concentrate is on the 32 people where the test was done, but the client didn't return to have the results read. So either one of those two things could kind of inform a project, and they would be different projects, wouldn't they? Yeah, they would be some kind of outreach, but basically, I think it would be a little bit different because the reason the tests were not done might be a little bit different than the client not coming back for whatever reason, and you don't know the reasons. So again, breaking them down, understanding what they are, is going to move you towards improving. So some obvious pitfalls, okay. If you pick a project that's too easy, do you really think that that's going to make that much of an impact with your clients? Probably not, right? If you pick a project that's too hard, do you think that you realistically may get the result that you want and the outcome that you want and be satisfied with the result? Again, probably not the way that you want it to come out. All right. Another thing that you may have some difficulty with is picking projects that are kind of given to you, for a nice term to put it this way, or forced on you by whoever, grantors, upper management, whatever. but the staff knows that this isn't really a priority and the clients don't really benefit from it, that's not a successful improvement project. Okay. And then, to me, the most egregious one is not using your data at all to drive the quality improvement project. Because if you don't use your data, then you're just going by lore of exactly what's going on. You're guessing. And that's not really in the quality improvement handbook 101. We don't like guesses. Another thing that folks somewhat do sometimes is not understand the organization's quality priorities, or just don't pick projects that align with it, okay? You'd like to think that the organization in which you work has a decent set of priorities for their quality management program and for quality improvement that you can all fall into line with and, embrace and move forward with it. Sometimes that just doesn't happen. It's one of the reasons why you do a quality management plan. It's one of the reasons why you work with your project officers at HRSA to basically, go over your plan, let them know what's going on. Federal guidelines shift, federal priorities shift. You have to keep in line with that over time. And you have to keep in line with your organization's priorities. So there's a lot to juggle with this, right? And I don't mean to downplay that. There's a lot to juggle. Another thing that folks fall into is thinking that you have to address everyone. I talked before about your client population has a overabundance of African American males over the age of 50. Okay, if it's great to try and address their specific needs. If you try and address everybody in the clinic with the same quality improvement project, you may be disappointed in the results, and you may consider it a failure when it's really a learning experience. And the learning experience is you need to focus. And one of the reasons why we talk about subpopulations is because they're different. The CQII is currently running actually, we're running a 2-day learning session right now virtually, but we're running a end disparities project. And we've chosen 4 subpopulations in agreement with HAB that we're focused on, and we do affinity groups. We do specific presentations to help folks address whichever specific population they've identified that they want to work with, okay? And it's those kind of targeted things that produce results, we hope, over time. So, setting your priorities. This may look pretty simplistic to you, but you'd be amazed in how it works out in practice. I'm going to stop again for a minute before I get too far into this, and I just want to make sure the folks that have question marks next to their name either still have a question or that might just be a remnant from before. So, Donna Hazelman?
Donna, do you have a question?
I think it's pretty much the same list of folks that checked in from before.
Okay.
Yeah. So I'll go ahead, but again, we encourage you to ask your questions in the chat room. We want this to be a really worthwhile learning experience for you folks, and please understand that this is kind of just the beginning of your quality improvement journey. It's A, lifelong thing. B, more importantly, it's something that the Center for Quality Improvement and Innovation is here to help you with, as well as the folks in Chicago are there to help you with. We do on-site technical assistance for recipients and also subrecipients. So if you're getting money from the Chicago Part A, you're considered a subrecipient. We can help you with an improvement project. We worked with Chicago in the past on different things and assisted them. So that's why we're here.
And Kevin, I can certainly share your information with the group. So if anyone wants to get in touch with you.
That'd be great. I'd appreciate that. So let's look at the priority matrix. This is a real, seemingly simple way of prioritizing what you want to work on. So let's say you have a bunch of data that indicates, I'll go back to the TB test again because it's easy, that the 32 people where the test was done but the person never showed up again. Okay. I mean, if anybody wants to take a guess at this, you can type it in the chat room. But where do you think those 32 folks would lie in this priority matrix? If I wanted to make them a target with whatever improvement project I want to do, would it be a quick win? Would it have a high impact with a low effort? Would it be a high effort but a high impact? So basically, the answer is, it depends. So it depends on exactly what you're thinking of in terms of an improvement project. If I want to find those 32 people and understand why they didn't come back, I may have to do 5 or 6 different things, okay? So it may have a pretty high impact because 32 out of about 100 people is pretty good, right? But it may have a very high effort. So it may be considered a major project. And is that what you want to do for a major project? Corollary to that is, if it could require a lot of effort, but it would have a low impact because bottom line is 32 people may not have come back because they moved or whatever reason. So you've only found maybe 5 of them. In this particular priority matrix, it's called a thankless task. It's a frustrating task. We can put it that way because you're spending a lot of time trying to do something that produced almost no result. By the same token, if you find something that has a high impact and not a lot of effort, it is a quick win, okay? But the impact is really what kind of drives this. There are some things that require a high effort, but that have a higher impact that are very, very worthwhile projects, okay? And that might help your organization a great deal over time. Major projects don't tend to occur in 3 to 4 weeks. Quick wins may occur in 3 to 4 weeks. But putting those ideas you have for improvement into a matrix like this and having the group, the quality management committee, the people that are kind of the key stakeholders in what's going to drive this, that helps you make decisions about where you're going to spend your time and your effort and gain the most reward for your patients, gain the most improvement in your patient outcomes, all right? Whether it's viral load suppression, even if it's looking at something like the intake of the patient into a clinic or into your community-based organization. I mean, I will just share this with you. I used to work in an organization in Brooklyn. It's a big organization, and we had over 24 HIV programs. One program was a prevention program, and it was funded by the city of New York. And the city of New York let a PhD student fill out the intake form because basically, as I used to kind of mockingly call it, it was her PhD homework. And bottom line was she came up with a 44-page intake form that was to be given to active injectable drug users. Now, for those of you who have worked with injectable drug users that are not in any sort of treatment or anything else and are still actively injecting drugs, you can imagine what it would be like to sit and basically administer a 44-page intake document to someone. So we were the most successful program. We actually got one person to do the intake, and it took 3 different visits. The other 4 programs that were funded never got anybody to complete the form. And I wonder why. That's the kind of thinking that you really need to put into this. And that's where this priority matrix comes in. So, again, where do you invest your time? Okay. Everybody can understand the quality priorities once you agree on them. And it gives focus to the organization. It gives focus to your improvement efforts. And hopefully that the team, quote unquote, will function as a team always does and function better at decision making than one individual alone. And there's a lot of stuff, a lot of work done on this, a lot of articles you can find about how teams perform better than individuals in most situations. It really just helps the team set a tone for the organization and maximizes your resources. So back to PCN 1502 again, and I want to say one word about this. In the Ryan White legislation dating back to 2009, the word clinical quality management was inserted within the law. HAB really went out of their way to define what clinical quality management is through this policy clarification notice, okay? And if you get this and read it, and you can download it from the HAB website, and it also has a really nice frequently asked question document, you can really understand what's expected of you, and it's right there, okay? What you're looking at now is how they define what quality improvement is. And what I talked about before are the performance measures for the service categories and things like that. It's all there. It's all there for you, and it makes it very easy to kind of set the tone for your quality efforts. Sorry, I'm still losing my voice. So the 3 methodologies that you see in front of you are just some of the many that are used in quality improvement. The model for improvement is something that HAB has used in the past. We, as CQII, and before that is the National Quality Center, have run different collaboratives based upon the model for improvement. That was something developed by the Associates for Process Improvement. And one of the things that it does is just look at what you want to improve and figure out how you're going to do that. And then it also incorporates a PDSA, Plan, Do, Study, Act methodology, which was really kind of an outgrowth of Deming's work. It's simple, it's very focused, it's logical, it makes sense, easy to teach people, and it's been around forever. Lean, which I alluded to before in terms of eliminating waste, had its beginnings with Henry Ford, believe it or not, although he didn't call it lean. But many of the kind of underlying precepts of it were used by then Toyota in what was called the Toyota Production System, which is lean, okay? So when you think about it, if any of you folks are in a lean organization or know lean, started in the automotive industry, a lot of quality improvement started in manufacturing. A lot of it. As a matter of fact, I read a paper that sort of attributed the advent of quality improvement to Eli Whitney. And for those of you familiar with Eli Whitney, he invented the cotton gin. What Eli Whitney also invented are interchangeable parts. So if your cotton gin broke down on the south side of Chicago, you could call up Eli, and Eli could have a part that broke in your cotton gin sent out, overnight Pony Express, to your location, and you could install it and you'd be up and running. However, if your machine on the south side broke down, you could call up your friend on the north side, and your little widget that broke in your machine, if your friend has one on the north side, he could get it to you and you could put it in your machine and you'd be up and running. Interchangeable parts made all the difference in the world in terms of quality. Because if you think about it, for those of you that own a car, if your water pump breaks, imagine if you would have to have one built specifically for you. You'd have a little downtime. So it all kind of evolves, right? It's the same thing with your quality program. It's going to evolve over time. You'll go from a little widget all the way up to this big, beautiful system. Six Sigma is based on statistical methods. And really, I never understood this before until last year, and I got a belt in Six Sigma. Six Sigma means that for every million things you make, you have 3 failures. It was really started with a company called Motorola when they were making integrated circuits. And they found that they had too many failures. Long story short, they got it down using statistical methods, got it down to about 3 in 1 million. That's what Six Sigma actually is. It's I'm forgetting the decimal places, but it really doesn't matter for this conversation. And they all have their own benefits and they all have their own drawbacks. So the model for improvement, as I mentioned, is widely used. You can not only figure out what you want to change, but you can figure out how to test it by using the model of improvement and the PDSA cycle. And this is the PDSA cycle. You plan your test, you do the test, you study the result, make modifications, and you act upon the result. And you keep doing that until you're very confident that your change is going to result in an overall agency-wide benefit. It's important to test, okay? One of the things that is kind of discouraged is basically rolling out something without testing the idea, because God help you if it doesn't work. It's going to create more chaos and it's going to build resistance to change as opposed to facilitating change. There's only one other thing that you can kind of do from here, and that's to just make this all happen. It doesn't have to be that involved. Figure out what your priorities are. Focus in on them, get your team together, and just do it. Make it happen. Look at your data. Figure out what you want to improve. See if it's realistic. Put your ideas in a priority matrix. Use a model for improvement. Okay? It's easy, and there's plenty of stuff available for it. And if anybody's interested, just let Estella know, and I can send you a bunch of stuff on the model for improvement. But the only way to make improvement work is by doing it. And that's all I have to say. So I went a little bit over. Didn't leave a lot of time for questions, but I'd be more than happy to answer any questions you guys have. And again, you can type them in the chat room. Any questions?
I think that might be it. What do you think?
Okay. Yeah, I think so. And again, if you guys think of something after the presentation, I guess, is it okay to have them email you, Estella? And then we can...
If you have any questions, you can email me, and I can certainly forward the information onto you, the question onto you. And I'll be,
that'd be great.
reminder, I'll be emailing everyone a link to the recording, as well as a copy of the slide set, and as well as a link to the eval form. And I think that's it. Thank you so much.